Assalamu alaikum warahmatullah. Welcome everybody on board. Actually, um, we will just continue the topic which we started 2 days ago, and which I will consider as the base of all our anesthesia management. So, just to have a recap that we started, that how will we evaluate a patient on the basis of history, examination, and investigation, and in that we have to keep in mind three things. One will be the surgery, the other will be the patient demographic data that will be according to his age, sex, personal habits, anything related to that patient. And also you will keep even comorbidities or anything special. Like for example, if a patient cannot listen or cannot see or anything like that, that will also be considered as a demographic data. Okay, and the third thing will be related to the disease, and disease with that disease effect on the multi systems. And just we have to extract the risk factors, we have to just extract that what will be the relationship with the anesthesia care. And with that one, we just chalked out that how will we chalk out that there is a risk for post-operative nausea vomiting, there is a risk of aspiration, there is a risk of difficult intubation or difficult mask ventilation or difficult extubation, things like that. And then all other steps like induction, maintenance, analgesia, post-operative course, where we have to send the patient after the operation. Like it may be a day surgery, it is an inpatient, it is ICU, it is HDU, patient need post-operative, any specific care like that. Okay. And with reference to surgery, all the surgical steps, like anything special which you need in any surgery, we chalked out. That's what we have done. If someone has not followed it, you can see the recording in the YouTube channel. And then in the next day we actually just try to have a look on some of the investigations. So we started with the baseline the concept of baseline investigation, which is there prevalent. We just converted into objectively that what will be the reason and what will be the inferences which you will get from those investigations, and then correlate what will be the business end, what will be you are looking at CBC, you are looking at PTINR, or you are looking at renal function or liver functions or whatever things like that, how to practically convert into objective management steps or anticipation or things like that. Okay, so that's what we did for CBC, LFTs, RFTs. We did discuss in detail about coagulation and anticoagulants, platelets. We just discussed some of them. Today, I was just thinking to have some detail, some more highlight of cardiac investigations or cardiac markers or things which you can anticipate, which can rule out in the pre-operative assessment, and how you can modify if you need to proceed with the case. Okay, so as we know that usually the cardiac symptoms which any patient will have will be the same, like chest pain or dyspnea or functional capacity, a decrease in functional capacity, or in the form of, for example, loss of consciousness, like maybe it is having some patient can tell about palpitation. So ultimately, whatever is this, and even some effects of the ischemic heart disease or cerebrovascular disease, you will consider them as part of cardiovascular system. So ultimately, if you find any decrease in functional capacity, number one, or you cannot assess the functional capacity, and you see that the patient has some risk factors. Okay, so there will be some sign symptoms, there will be some risk factors. Okay, and there will be you can say clinical and surgical risk. Okay, so then these will be leading to some of the investigations, which may be ECG, echo, what else? Holter, thallium scan. Can anyone tell some of the investigation which we can do with reference to cardiovascular system? Anyone, please?
Stress testing.
stress testing. Okay. So stress testing, actually thallium scan is one of the stress tests. There is another specific
Treadmill
test.
test.
I'm sorry.
Treadmill test.
This is stress test. This
Treadmill
is
test.
exercise tolerance test. Okay. Am I right? And there is an advanced form of exercise tolerance in the form of this CPEX, cardiopulmonary exercise testing, in which not only they see any like change in cardiovascular perfusion, they also see the utilization of oxygen. Okay, so the business end, like you can say, the heart lung relationship. Maybe you have not hear this word in a number of books, but actually this is the business end. And because when you open the books, you will find what lipid, yes, lipid profile, yes, we will come back to it. Thanks for reminding. Actually, I forgot about it, but we will cover it. So anyways, so heart lung relationship. Okay, so remember one thing, whatever we are trying to investigate, there is a the correlation, strong correlation between the heart and the lungs. Cause if any of them is not functioning, ultimately functional capacity will decrease. Okay, either the heart is not able to pump, or lungs are not able to have the exchange. Okay, if the lungs are not able to have the you can say exchange, CO2 going out and oxygen coming in, and then heart is pumping, and the third step is actually, if both of these things are okay, then the third step will be there with reference to utilization, which may be problematic with reference of like any condition in which oxygen is not being utilized in the form of, for example, sepsis or cyanide poisoning or anything like that, gangrene. Okay, so that will be a third thing, but usually you have to focus, and actually whatever we are doing with reference to this thing. Okay, there are certain other things which are related to, as mentioned rightly. So with reference to lipid profile, I will add cardiac enzymes. Okay, so cardiac enzymes, you can have some change in cardiac enzyme, and actually some are acute cardiac enzymes, and actually some are in the chronic form, in the form of like heart failure, this ANP and BNP. Okay, so these are also some of the markers which can tell you about the heart failure. Okay, so like acutely we see at TROP-T or I or CPK, CKMB. Okay, so that's what we see in the acute setting, and in the chronic, if you are evaluating, maybe these tests may be required. So you should have an idea. If you are evaluating any system, you have to see, and with reference to here what we were saying, stress testing, there are certain testing which you have to do later on. One of them will be angiography. Okay, and there is cardiac CT. Okay, and with thallium actually is stress thallium, because what will happen that, for example, if you find any uh, BNP, CKMB, yes, dobutamine I was just coming to it. So
मेरे
stress
दोस्त
thallium,
से बाद में जिसने हाउस जॉब
can you
किया
mute,
है
please
मेडिकल
can you mute
ऑफिसर
yourself, please?
स्पेशलिस्ट किया है
This is please, I request you humbly to keep yourself muted. Okay, anyways, so stress thallium, so I just want you to understand the concept. There is one stress thallium, there is one stress echo. Okay, there is one, as I mentioned, ETT, exercise tolerance test, and the latest form, CPEX testing. So all of them are tech checking. This will tell you any perfume defects. Like they will give either in normal condition or by giving a stress, and then they will see any perfume defects. Same you can check with cardiac CT. That will also tell you the patency of the vessels, and like thallium scan will tell you the thallium scan for perfume. Yes, okay. Thallium scan will not tell you the exact. So next, for example, if you find anything, if you find a perfume defects, you will go towards angiography, okay, or cardiac CT, because angiography will tell you exactly how much blockage is there. So the sequence of events is like that. And angiography, again, angiography may be in two forms. It may be diagnostic, it may be therapeutic, because maybe if there is some signs of ischemia. Okay, and then you refer the patient for angiography. Maybe they will do the therapeutic angio if the patient is needing any stunts. So they will go either bare metal stunt or only balloon opening or drug eluting stunt. Okay, so you have to be understanding the concept. Maybe this is very basic thing, but this sometimes if you have a good concept, it will be easier for you to understand the situation. Okay, and one more thing, that in stress echo, as was mentioned in the message box, the butamine stress. Okay, so they give the butamine of they just check the they just give a stress to the heart, and then they see any change. So with reference to ischemia, the thing will be starting with, what will you see in the echo? You will see uh like inna lillah. You will have hypokinesia.
Ejection fraction.
No, I'm sorry, not ejection fraction. Hypokinesia and akinesia. Before that, there is segmental wall motion abnormality. Okay, so the segment of any wall in which there is decrease in perfusion will not contract nicely. So this will be the first thing. And for that, actually, even if you can have a transthoracic echo, but more reliable is the T, transesophageal echo, which unfortunately is not common everywhere and not everyone is expert. But actually, this is the future, because if you have a patient at risk. Okay, so because this will be the business end. If you have a patient at risk, you will do all the invasive monitoring, like you can have a CVP, you can have arterial line, you can have a pulmonary artery catheter, you can have cardiac output monitoring. But the most reliable thing, which will pick the earliest of the problem, is the transesophageal echo, which will pick even the segmental wall motion abnormalities, which will lead to hypokinesia, and which will need to akinesia. And then your point will come, whosoever was saying about ejection fraction. And actually, we are very happy if ejection fraction is normal. We are very happy. I will tell you in few moments that what is the ejection fraction normal is the most unwanted thing or useless thing to be known. Okay, because ejection fraction normal is not a guarantee that there will be no problem. There are something else. Okay, misleading, yes. Oof. I request you humbly, please keep your mics muted. Okay, it's a big distraction for me. Anyways, so like as I mentioned to you, that this is the sequence of the things which you have to do. Okay, angiography, stress thallium, stress echo, cardiopulmonary exercise testing. I will request you to note down these words and have a look on the Google about each of them. You will understand what is the utility of each of the investigation. Okay, so because ECG, normal ECG, if you are looking at it, maybe you are looking at the rate may be normal or high or something, then you will see the rhythm. Okay, the rhythm may be sinus or it is not sinus. There is irregular rhythm.
आप सुनेंगे सर नॉर्मल है पर
There is arrhythmia in the members, just like I'm telling you about arrhythmias. Anyways, so if there may be some rhythm other than sinus rhythm, then you may have some problem in the axis. Okay, then you may have some blocks. Blocks may be in the form of first degree, second degree, or third degree heart block, or Bundle-Blanch block. Okay, so you will find any of these things. And then hypertrophy. You can find right ventricular hypertrophy or left ventricular hypertrophy or right ventricular hypertrophy. And then you can have effects of some electrolytes, like you can have effect of potassium. Okay, hypokalemia or hyperkalemia, magnesium. So these are magnesium, calcium, you can have some finding like that. If the patient is on any specific medication like digoxin or because for us, actually, this is the most, the common things are more important for us. Okay. And we should be knowing that what are the bad arrhythmias. Okay. So, for example, SVT or VT or AF, both F, flutter and fibrillation, and bradyarrhythmias. Okay. Usually they are more important for us. And also left bundle branch block, because left bundle branch block is maybe saying that there is some ischemia going on. If there is bradyarrhythmias, maybe there is ischemia of the conducting system of the heart. So you should be knowing about these things. And remember one thing, maybe all these arrhythmias are with hemodynamic instability or stable or unstable. Okay. So that's how you will proceed with it, because you will find these things or you need this information either preoperatively or intraoperatively. Even you can say perioperative period. You will you don't need to have a very detail in the X-rays what is happening, because at the end of the day for you, more important thing is because you will be giving any stress, either it is an elective surgery or emergency surgery. Because elective surgery, if you have any doubt, you will not proceed. And in emergency surgery, you can just try to avoid the stress. Okay. You can avoid the medications which are which are creating further problem or enhancing your problem. Okay. So remember one thing, you should have a concept to approach like that. Okay. Because maybe resting ECG is normal, but you see the functional capacity is not good. Okay. So you have to correlate functional capacity. And another, I will tell you, functional capacity is in the form of METs. Okay. So you are evaluating the history and you do some examination. Then you find that patient has osteoarthritis, patient cannot move, or patient has fracture, or patient has anything in which you cannot evaluate. So you have to go to stress, pharmacological stress. You cannot do the physical stress. Okay. So in that case, you cannot have the, because there are some other terminology you will find, shuttle test and walk test, something like that. These are details. This is actually not much of our interest, but sometimes as like as an anesthetist, you should know everything. So maybe you can find. So in that case, neither you can have a walk test, you cannot have a running test, you cannot have like things like that. You have to go for pharmacological dobutamine stress or stress thallium. So this is the concept you should be knowing. Okay. So I repeat, ECG, echo.
Sir, what,
Yes,
sir,
sir.
what about Holter monitor?
Yes, yeah, I will tell. Thanks for reminding. So let's finish Holter also. It slipped out of my mind. So there are two things. One is Holter and one is ambulatory blood pressure. So I will tell you the importance of these things. If you have any, like patient is giving you a history of palpitation, patient will not tell that I have SVT, or I have frequent PVCs, or I have this one. But remember, I will share you something funny, that when I was stuck in my exam, I have all sort of arrhythmias going on. I had frequent missing beats, so I actually underwent Holter. And Holter, what they do, they attach the ECG, fix it, and they give a machine which is there in your pocket for maybe 48 hours, and then they evaluate. And the next step, if for example, if they find that there is significant arrhythmia, so there is another next step to Holter is either it can be evaluation of ischemia, but if the ischemia is not there, they do a thing which is called as electrophysiological study. Okay. Electrophysiological study. There are few centers in Pakistan even which are doing like a PIC, I think NICVD they have, but it is not frequently known by people. So Holter is to see the arrhythmias, is to see the ECG rhythms, which maybe in the normal ECG you are doing, you are not finding anything, but patient is giving a history of palpitation. Patient is
क्या प्लान है
patient is
बताओ
giving history of even patient is giving you a history of floaters, or patient is giving history of unconsciousness, and you are not finding any apparent reason. So you will go for Holter. And next for Holter is electrophysiological study, and even they are doing radio frequency ablation. They find the culprit area and they do the ablation. This is detail, but I'm just telling you for you. And the other thing, ambulatory blood pressure. Okay, so ambulatory blood pressure is also just like Holter, but instead of ECG, this is for blood pressure. Like for example, it is for the diagnosis. If the patient has borderline diagnosis, and you have to sure how much is the overall changes in fluctuation in the blood pressure, they put a BP cuff and it is constantly taking at a certain specific period, and it is giving you a result. Okay, so this is two things which is in addition to what we have discussed. Anything which I have missed, please point it out, because I am not opening any book to tell you. I am just telling you spontaneously. So I am prone to miss some things. Yes, lipid profile.
Excuse the
Yes, yes.
lipid profile, sir, and Marfan syndrome and congenital heart disease, like.
Yeah, because I will be telling you something about further findings in the echo. So lipid profile, actually, there is one good lipid which is HDL, and the rest of them is LDL and VLDL and the cholesterol. Okay, and this what is else is there? Triglycerides. Okay, so if because HDL should be higher and LDL should be low. So if the patient may be taking statins, so whenever you have a high changes in lipid profile, either they are taking statins or there are some other medications. I don't remember the name for triglycerides. Usually, if the patient is taking statins, you should be looking at the LFTs. Okay, because any patient who is taking statins, there may be change in LFTs. So this is the correlation with you, and statin need to be continued, and you will be surprised that statin is one of the medication which is increasing the overall life expectancy in a patient with some ischemic heart disease or things like that. Okay, another, now a few words I have, actually I will suggest you to have a look on the I will try to I will try to share the link again, because I had taken a detailed class of echo before, but I will just try to tell you one portion we have covered with reference to ischemia. Okay, but there are certain other things which you should be knowing. One of them will be, for example, chamber clot. Okay, there will be certain condition in which you will be looking at the chamber, and you will, maybe there is some clot. So this is important because it can have embolism. Number one. Then you will see the valves. Okay, so in the valves, if it is, for example, stenotic area, so you will be looking at the size, and then you will looking at the transvalvular pressure gradient. Transvalvular pressure gradient, because this will be telling you how significant the stenosis is. Then if it is regurgitant lesion, so you will have regurgitant fraction. Okay, regurgitant fraction, because regurgitant fraction, for example, there is a backflow, so you will be seeing how much is going back and how much is going forward. So if it is gradually, if it is too much is going back, so the heart will start filling, and there will be chamber, not only chamber clot, there will be dilatation. Okay, dilatation. So you will find these things in the echo report. Then very important thing, people are interested in only ejection fraction. Okay, so the class in which I took, I just write it in it, their information more than ejection fraction is normal, sir. Okay, so remember one thing, the more important thing is that heart, if not receiving the blood nicely, as occur in hypertension. Okay, so in hypertension, chronic hypertension, it leads to left ventricular hypertrophy. Okay, so usually this sort of hypertrophy is concentric hypertrophy. Concentric hypertrophy. So what happens, gradually the relaxation will be decreased. Okay, so according to this Frank Starling principle, if the heart will not relax nicely, it will not be able to receive blood nicely, and it will not be able to have the same pumping. Okay, so this is very important. Then another thing, usually if you just recall cardiac cycle, the atrial click has around 10% contribution in the cardiac output. But if you have diastolic dysfunction, usually this is in the form of E over A ratio. You will find this in your echo report. Usually this is a normal ejection and this is the atrial contraction. So usually what will happen, normally this E or A will be more than 1. Okay. Normally that like patient is receiving all the blood with the normal ejection. But gradually, kick will become more and more important. So any patient in which there is diastolic dysfunction or any problem like patient has mitral stenosis, for example, so there is stasis of the blood in the left atrium. The heart is not filling nicely. Left ventricle is not filling nicely. So the requirement of atrial click is becoming more and more important. So if that patient goes in atrial fibrillation, the cardiac output will become terribly low. Patient will not be able to maintain it. So I repeat, E is for ejection, normal, and A is for atrial contribution. To just because this is echo finding, so you can just oh yes. Sorry for wrong word. It's kick and click. I'm just telling you that giving you the concept. Okay, so atrial kick is the word. I think yes, you are right. So thanks for correcting me. So I'm just telling you that this is how we proceed. So if you are looking at the echo report, please ejection fraction. If it is normal, it is not at all significant. But if it is low, it is definitely significant because it means the heart is going to fail or heart is not able to pump nicely. Okay. Then, and the last thing which you see in the echo report is pulmonary pressures. Because if the pulmonary pressures are high, it means that there is a strain on right ventricular. Okay. And right ventricle can fail. Pulmonary pressures, if they are high, it is just showing maybe reason, maybe anyone. Because if there is mitral stenosis, gradually the pressure is going towards the lungs, and gradually pulmonary hypertension will develop, and then the effect will be on the right ventricle. So this is the cycle from which goes on. But there are certain other reasons for pulmonary hypertension, as was mentioned in congenital heart diseases. Okay, in congenital heart diseases in the pediatric patient, they have right to left or left to right shunt. Okay, usually these shunt will be after birth. It will be left to right. Okay, but gradually what will happen if chronically it's there, the lungs will again develop the same pulmonary hypertension, and then it can reverse, and that will be causing the cyanosis. That is called as Eisenmenger phenomena, in which the left to right shunt is reversed and it becomes right to left. And that is what happens in, for example, Fallot's tetralogy. So that's why whenever they have dead spells, they are asked to have squatting, like they clench the teeth and they have the contraction of the muscle. So what happens? Increase in systemic vascular resistance. So when the systemic vascular resistance is increased, then the back pressure goes and there is decrease in the shunting from the right side of the heart to the left side of the heart. Okay, so this is the some basic of the thing which you were asking. Of course, this is too much detail about it, but I repeat, you see the systolic function, diastolic function, valves, chamber clot, and then you overall you see that whether there is a problem in the form of like regional wall motion abnormality, hypokinesia or akinesia. I will request you to have a look on echo with a new eyes, with a new glasses. So you will come to know that how badly we see at the echo report. Okay. So like I have just tried to give you an overview of how you should evaluate intraoperatively. If anything happens, you will either see the changes in the ECG, you can have cardiovascular instability, you can have arrhythmias, you can have fall in blood pressure, or like patient, maybe you don't appreciate anything, and at the end of that, like if the embolism have, for example, occur, or there may be stroke. So maybe in any cardiac event, the end result, you can get it at the end of the surgery. Okay, maybe intraoperatively, you can find a number of things. As I told you, there will be MI, there will be cardiovascular instability, arrhythmia, hypotension, severe hypertension may be followed, may be preceded before hypotension occurs. Okay, so this is just like if you have any problem like that, you will anticipate such problems. Then we will discuss in detail about MI, but I'm just going. I was just telling you how to correlate. Okay, so ECG, enzyme, Holter. I've just given you an idea. Chest X-ray. Actually, I think I will discuss inshallah chest X-ray with reference to both cardiovascular system and respiratory system tomorrow. Okay. I am because sometimes if the discussion is too long, unfortunately, some of the people lose their strength, the interest. I hope you people are getting understanding. Okay. So any question you can again I invite all of you to drop a question anytime to me on WhatsApp, and I will be very happy to answer. Okay. So thank you very much. And again, as I showed you yesterday as well, you can have a look on the recordings before, and you will find the previous recordings in the channel in the form of this playlist. Okay, so you will find a number of things which I have done. The pre-operative things I am putting here, the one which I have just recently started, but actually before that in cardiovascular system, just let me show you. Just a second, please. Okay, so this is before I have done in detail, like pediatric patient for anesthetics, pregnant patient for anesthetics, renal disease patient for anesthetics. I have discussed all these things before many times in detail. So I will invite you to have a look at it. You will maybe, if the things which I am not able to highlight you at the moment, maybe I have discussed before how to evaluate cardiovascular system. Okay, so like that. Echo I will share with you. Okay, so tomorrow inshallah we will make our. Can you please share link of your channel, sir? Are you in the WhatsApp group? Just message me. If you are not on the WhatsApp group, you just I share the link daily. Believe me, I share the link daily. The channel is Anesthesia Knowledge. You can find picture of me and my father here. Anesthesia Knowledge. You will write Anesthesia Knowledge and you will find. If you don't find it, you can drop a message to me. Okay. So thank you very much, all of you, for your presence. We will meet tomorrow, inshallah. Okay. Bye bye. Assalamu alaikum.